Over the past 15 years, we've had a dramatic change in the tissue that's needed to diagnose a patient with non-small cell lung cancer. Certainly it wasn't too long ago, and when many of us trained, you could get a fine needle aspirate that showed a few cancer cells on a slide and be content that you had a diagnosis of non-small cell lung cancer and you had enough information to treat the patient. Over the past 15 years, we've had a dramatic alteration where now, in addition to knowing just that it's non-small cell lung cancer, you have to understand the tumor histology. So is it a squamous cell histology, adenocarcinoma, a large cell? And you have to have enough tissue to do predictive biomarkers. These predictive biomarkers can include PD-L1 as well as tumor mutation testing. Now, you can't get all that information off of one slide from a fine needle aspiration. You have to get more tissue than that. Sometimes the tissue can be obtained through a transbronchial biopsy by a EBUS, so endobronchial ultrasound or regular bronchoscopy. Sometimes you can do it with a CT-guided biopsy. Sometimes you can do it with a thoracic surgeon doing an open biopsy. Whatever technique you use, you just have to get enough material and material of the right kind to allow the mutation testing, the biomarker testing that you want. Importantly, one of the key biomarkers for lung cancer is a marker called PD-L1. Now, PD-L1 is not FDA approved as an assay on tumor cytology. So to be truly compliant with the biomarker guidelines, you should get a biopsy specimen. So that would mean a CT-guided biopsy or even a needle biopsy in a transbronchial biopsy, but it has to be a histology specimen, not a cytology specimen. Overall, all these techniques over the years have really moved forward in getting more tissue from our patients with lung cancer, and it allows us to test all the biomarkers we want.
The first step to ensuring that suitable tissue for molecular analysis is collected during lung biopsy starts with a conversation prior to that biopsy. Ideally, this conversation happens in a multidisciplinary tumor board where the various practitioners to whom that testing would be of relevance are present. That conversation starts with the appropriate place to test to ensure getting adequate tissue and to ensure that it's done safely and comfortably for the patient. In general, more peripheral lesions are accessed via CT-guided route, and more central lesions increasingly are being accessed through endobronchial ultrasound. That conversation continues with what's going to be important for this patient. And this comes to the question of pre-analytics, how the tissue is going to be handled once it's obtained. This idea of tissue stewardship may get a little bit mundane, but it's actually really critical for the right thing to happen. The person obtaining the biopsy and the pathologist need to have a good communication and understand what we're using this for. For example, if we're biopsying bone for the purpose of molecular characterization, it's really important to not decalcify the specimen. If we already know that the person has adenocarcinoma of the lung and we're doing a biopsy to get additional molecular information that was not previously obtained, then it's important to not use up the specimen doing a lot of IHCs proving it's lung cancer and so on.